Hi everyone, welcome back to the channel. My name's Kevin, a new grad RN here to break down complex nursing topics into simple bite-sized lessons. Today we're picking up where we left off last week when talking about cardiac drugs, but today we're going to be specifically talking about calcium channel blockers and digoxin. These are probably the last two cardiac drugs that I found extremely testable in nursing school and on the NCLEX. So we're going to go over some key differences, side effects, and the early versus late signs of digoxin toxicity. And keep in mind, this is just supposed to be like a preview of the topic. It's only supposed to give you the very basic understanding of the drugs. These can go way more in depth, but I'm trying to keep it simple for people that are struggling or that just want a good baseline of understanding. So we're going to start off with calcium channel blockers. They lower blood pressure, but not all calcium channel blockers are created equal. We have two main types. We have the non-dihydropyridines, which consists of rapamyl and ditalazam, and we also have and dihydropyridines, which is usually nifedipine. So with non-dihydropyridines, they act on the vascular smooth muscle and the heart, whereas dihydropyridines, the nifedipine class, usually acts mainly on the vascular smooth muscle. So the way I like to remember it is that non-dihydropyridines, the two popular ones, rapamyl and ditalazam, make up this mnemonic called very nice drugs, right? So it stands for rapamyl, non-dihydropyridine, ditalazam. Also, it's a longer name, the drug class, the non-dihydropyridines. It's much longer than just dihydropyridines, right? So I think the longer the name, it does more things. That's how I remember it acts on the vascular smooth muscle and the heart. Okay. You mainly use it for treating like dysrhythmias, and it can cause severe cardiovascular effects. So you want to make sure you're monitoring the blood pressure and EKG. On the other hand, the dihydropyridines, since they only act on the vascular smooth muscle here, there's very little blockade of the heart calcium channels. It does cause vasodilation, but it can't be used to treat dysrhythmias, okay? So, and I'm going to give some examples of rapamyl here, like their adverse effects. One of the most testable things about them is that it causes constipation. This is the most common complaint. The way I remembered that was C for constipation and C for calcium channel blocker. So they cause this constipation effect, and it's more severely for the elderly. Some other important adverse effects that I found pretty testable were the gingival hyperplasia, which is the bleeding of the gums, and the heart block. But this one was not as common as the constipation and the hyperplasia. Some other adverse effects are usually blood pressure related, such as dizziness, facial flushing, headache, and edema of the bilateral lower extremity / feet. This one's not exactly blood pressure related, but it's still in the cardiac system, okay? Now, the dihydropyridine, the one that does less stuff, the most testable adverse effect was mainly the gingival hyperplasia and the reflex tachycardia. It's important to note for the reflex tachycardia, you can give beta blockers to prevent it, which we kind of should know by now since it's a very popular drug class. If not, we can go into it. But it's important to know that beta blockers can intensify the adverse effects of rapamyl and ditalazam, which are the non-dihydropyridines. So this is why beta blockers is usually not really a contraindication, but you need to be sure if you want to give it with a calcium channel blocker. So it's something that you could verify with the MD or whoever the provider is to make sure, like, hey, you ordered a beta blocker and a calcium channel blocker, just checking to make sure we're not going to bottom them out. Or you can also check with pharmacy too. The adverse effects, likewise, flushing, dizziness, headache, and peripheral edema. So these are all like blood pressure related side effects, which is to be expected since these two drugs affect the blood pressure. Now, digoxin is another very popular drug, but we don't really see it used in practice that much anymore. But for some reasons, they still enjoy testing on it because it has a very easy thing to know about, or like a very easy catch. So first we're going to talk about the class. It's a positive ionotrope, okay? So what that means is that it improves contractions. How I remember what positive ionotrope means is that digoxin digs for a deeper contraction, okay? So like when you're looking at that EKG, it's digging for that bigger contraction with that deep groove, okay? Now the big thing with digoxin is that potassium must be kept in a normal range, okay? And the reason is because it binds on the same enzyme as digoxin. So they're both competing for the same spot in the body's receptors, okay? So when potassium is low, more digoxin can bind, which causes toxicity. And a very common test question that I can almost guarantee you would either be on your NCLEX, HESI exit exams, or just your nursing school exams would be early versus late signs of digoxin toxicity. Okay. Early signs include GI and neuro, which is like usually loss of appetite, nausea, vomiting, diarrhea, abdominal pain, headache, confusion, anxiety, hallucinations. Now, late signs are cardiac arrhythmias, some confusion, so a little bit of neuro here, blurred or yellow-green halos, okay? Now, if the question just asks you what is a sign of digoxin toxicity and it doesn't specify early versus late, and the answer choice says yellow, green halos, or blurred vision, you can pretty much confidently pick that, okay? But if you read the question carefully and they distinguish between early versus late signs, then you might need to remember the early signs, such as the very vague GI symptoms and a little bit of neuro, okay? Mainly it's the GI symptoms that they will test you on. But the biggest thing to remember is the yellow-green halos and the blurred vision. That is the number one adverse effect of digoxin toxicity. Just remember that if they clarify between early versus late, you may need to think and dig a little bit deeper in your knowledge, okay? Some nursing practice things you should know is that before administering digoxin, you want to check the heart rate and K levels, okay? Why? We kind of just talked about it for the K levels because it can cause a digoxin toxicity, okay? Some interactions is that interacts with diuretics, ACE inhibitors, and ARBs. And this is what we covered last week, right? We kind of talked about diuretics. We did only talk about spironolactone, which is a potassium-sparing diuretic. But most diuretics are potassium-wasting. And like we just saw on the previous slide, when we have lower potassium, the digoxin toxicity has a higher chance of happening because there's less potassium in the body and DIG is trying to bind onto it, right? The flip side can also be true, where ACE inhibitors and ARBs usually cause a higher amount of potassium in the body. One of the big side effects I told you guys to remember last week was that it causes hyperkalemia, high amounts of potassium in the blood, right? And when there's high amount of potassium, that means there's less room for digoxin to bind, which means that the drug may not reach its potent dose. And also, just on a fun note, verapamil can also interact with it, okay? And some little small details about the pharmacokinetics about digoxin is that it crosses the placenta, it's mainly eliminated by the kidney, and it has a half-life of 1.5 days. So the biggest takeaways from this section is that be careful with mom and baby, and if they have kidney damage like AKI or CKD, like acute kidney injury or chronic kidney disease, digoxin may be retained in the body a little bit longer, which could be toxic. So this is just a little bit of extra critical thinking that you guys can apply when you guys are looking at these types of questions. And that's all for today. Sorry for the short video. I had a pretty busy week in my second week of my new grad position, so sorry for a short video, but mainly calcium channel blockers and digoxin are two drug classes that are very testable from the cardiac drugs. The rest are kind of just here and there. So hopefully this helps. Let me know if you guys have any other questions. I'll try to answer them. And any other topics you guys want me to cover. Good luck studying. Bye-bye.